good. Look, I'll talk about refining transplant disease states based on genome-wide gene expression studies, and it's really a privilege to participate in this very creatively structured symposium, and I'd like to congratulate the organizers. I'm really enjoying the symposium. These are my disclosures, and I guess my thrust today is that therapy for kidney transplantation has stagnated for the last 20 years since the great age of the randomized clinical trials. We've had very few successful, in fact, essentially until recently, no successful placebo-controlled prospective clinical trials. I believe we're on the cusp of a new era, and it will require changing out, and this will change outcomes, and it will require new laboratory test support, but it's going to be very exciting. So we'll talk about the evolution of the MMDX system and its relationships to the other tests. So we'll talk about 4 tests: MMDX, local histology, cell-free DNA, and DSA. And then we'll talk about how this is guiding the development of the new therapies. I'll give you the results from the felzartamab study. So MMDX evolved in a clinicaltrials.gov environment. So we've had 216 investigators in 79 international centers in 7 clinicaltrials.gov programs. And I'd like to thank our collaborators, but more than that, I'd like to thank the thousands of patients who've consented to these studies and made this possible. So that they are the heroes of this study, the patients who have participated. Now, we have licensed the technology, and the technology license helps to support the research. So the mothership is in Edmonton, where the technology and the software is established, and then we've got exact mirrors of the technology. This is not a kit. We go to these centers and establish exactly the same technology in each of these centers in Portland, Oregon, in Prague, and Vienna, and others are in progress. So MMDX is a central biopsy diagnostic system that uses genome-wide microarrays to measure gene expression in intact RNA, stabilized in RNA later. And we compare the biopsy. These measurements are very precise. Of course, there's biopsies vary, so there's sampling variation, but the measurements themselves are almost perfect in terms of reproducibility. And we compare the biopsy to a reference set using ensembles of up to 100 machine learning algorithms. So we measure the RNA for 19,000 genes, and we interpret the disease states using machine learning algorithms. So we measure the rejection states and the injury states. And the injury states we don't usually look at those, as we tend to be focused on immunology, but the injury states is what determines the patient's function and outcome. So you give us a piece of the biopsy, and in case of kidney, it's 3 to 5 millimeters of the core, and it's stabilized immediately in RNA later. Then this goes to the MMDX center, usually overnight in FedEx, and then we take the RNA out of the biopsy, we put a label on it, we hybridize it to the chip, and then the next day we can use lasers to develop the light signals and turn those into spreadsheets with thousands and thousands of numbers. And then our machine learning algorithms translate that into a report. So the report is for rejection, identify 7 rejection classes. No rejection, and then the ABMR, the antibody-mediated rejection states, and the TCMR states. And so we identify early stage ABMR, fully developed ABMR, late stage ABMR, minor ABMR, TCMR1, and TCMR2. Now they're distributed here in principal component analysis. So we get principal component 1 is all rejection, and principal component 2 separates TCMR from ABMR. And then if you take that cone-shaped cloud of data and you rotate it to look down the barrel, you see principal component 3, which separates the stages of ABMR, early stage, fully developed, and late stage. Now, there's another way of looking at it, and David Briscoe has already shown you this method, which is to look at all the variants in 2 dimensions, which is called UMAP. And when we do this, we see that, first of all, the biopsies are continuous. They're not separating into blobs. And secondly, we see an ABMR ear and a TCMR ear and a no rejection ear. Now, this boundary between rejection and no rejection has been drawn because we did machine learning on the states we had previously developed in the BAMF system. We've been working with the BAMF system since 1990, since the beginning. And so we're very interested in these no rejection biopsies. We got a surprise. So this is the report that we generate. So the report we generate shows a new biopsy. This is a biopsy that was sent to us from another center in one of our studies. And this patient is 71 days post-transplant, and their biopsy projects up into this space. That's not where you want to be. You want to be down here in no rejection. So in principal component 1 and 2, this biopsy projects up here on the boundary between early stage and fully developed ABMR. And you can see this more clearly in principal component 3. This patient's biopsy is on the boundary. Now, if we look at that in UMAP, this is where the patient is in UMAP on the boundary again of early stage and fully developed ABMR. We also show you a random forest to say how much rejection activity there is. This is all antibody-mediated rejection. There's no TCMR here. When we show you the injury state, we don't have time this morning to discuss the injury states, but this is real nephrology. This is normal. This is CKD. This is AKI. This patient is pretty close to normal, probably some residual AKI from the transplant process. We show you again, this is another way of projecting this. And again, the patient is pretty close to normal. This is the injury UMAP. And we show you the survival curves for biopsies like this in the reference set of 5,086 biopsies. And these biopsies like this one have survived pretty well over 3 years. Remember, ABMR has a long-term effect. Its effects are not short-term. All right, so I wish it was that simple. Remember, these are the no rejection biopsies, right? Now, if we actually turn this from being a dichotomous presentation to a continuous activity, we see something surprising. The molecular rejection activity goes below the boundary into the no rejection biopsies. The molecular ABMR activity goes very much below the boundary into the no rejection biopsies and also into the TCMR biopsies. And the TCMR activity extends into the ABMR biopsies, but also very much into the no rejection biopsies. And it matters. This influences the future events for those patients. And we don't know, none of us have ever been treating this sub-threshold activity before, but I think we're going to have to think about it because it's there. All right, the other complexity of this was that we found that ABMR is 50% DSA negative. When we compare the molecules that are associated with ABMR in the DSA negative patients on the y-axis to the molecules associated with ABMR in the DSA positive patients, we get a line. In other words, it's an identical state molecularly. It has some differences in timing and in intensity, but overall it's the same state. And you can say, well, this is classified molecularly. What if you looked at ABMR histologically classified and it's the same thing? So in fact, DSA positive and DSA negative ABMR are a new problem for us to deal with. Now, what determines prognosis? Prognosis is determined by injury. Now, we've got 3 measures of injury here. We've got the GFR in clinical measurements, that's green. We've got molecular injury in the biopsy, and that's orange. And then we've got rejection activity, which is blue. In the random forest, survival is predicted by the GFR and molecular injury, but it's not predicted by the rejection activity. So rejection activity is very important. It damages the parenchyma, but the parenchymal damage determines what's going to happen to you. We'll come back to that point. Okay, so we've been very interested in antibody-mediated rejection. We've defined the ABMR activity genes, and they are 2 classes: interferon gamma inducible activity genes and NK cell expressed activity genes. Again, suggesting this is an NK cell mediated activity process. We also see the stage changes. Now, we recognize these for decades now in the histology and electron microscopy. So there's endothelial changes, and they occur over a longer period of time. And then there's the nephron injury, which is why I've just introduced that to you, the injury genes. Now, what's the relationship among these 4 tests? This is what we call the 4-body problem. And we've studied this in the trifecta kidney study. So we're assessing the relationships between these 4 tests. All of them have valid relationships to ABMR. And the hypothesis is that when experts, like tests, agree, are known to be validly able to appreciate some entity, which is unknown, the degree to which they agree with one another shows their proximity to the truth. So when we did this, we use what are called partial correlation plots. And we see the best correlations are between MMDX and cell-free DNA. Each of them have some relationships to histology ABMR, and each of them has some relationships to DSA. Interestingly, MMDX is more closely related to DSA than histology is to DSA, in spite of the fact that histology uses DSA in the BAMF system, meaning that the rules that histology is using for interpreting DSA, and especially DSA negative ABMR, are probably not optimal. So the hierarchy of correlations shows MMDX and cell-free DNA beating MMDX versus histology, beating MMDX versus DSA. And then come the other associations. So this gives you a sense of the hierarchy of our appreciation of truth with our tests. So we've got contradictions between MMDX and histology. And so when MMDX is the top test in terms of these partial correlation plots. So when MMDX says you have ABMR, MMDX said there was ABMR in 179 biopsies in this study, and histology agreed in 34%. Sometimes histology called them possible ABMR, sometimes they called them no rejection, sometimes they called them TCMR. When MMDX recognized pure TCMR in 37 biopsies, only 15 were called TCMR by histology, 41%. And in no rejection biopsies, when MMDX said there was no rejection, histology agreed in 69%. Then when we looked at the cell-free DNA and the MMD and the DSA in the various MMDX classes and the various histology classes, overall, there was a lot of agreement. So MMDX says that in no rejection, cell-free DNA is low and DSA is low, 20%. In MMDX ABMR, cell-free DNA is high and DSA is 50%. And in TCMR, cell-free DNA is moderately elevated, but DSA is not. And histology essentially across all the biopsies is similar. The problem is once you get down into the discrepancies. So we did a discrepancy analysis of cell-free DNA and DSA in the biopsies that called no rejection by local histology. And in these biopsies, 362 biopsies, cell-free DNA was overall low and DSA was overall low. But when you looked at the MMDX positive subset of these biopsies, cell-free DNA was high and DSA was high. So there is within the no rejection biopsies by histology a subset of genuine ABMR, which is being missed. Now, I told you that there's subthreshold activity. So across all the biopsies, MMDX ABMR activity correlates with DNA, with the diagnosis of ABMR in histology. They correlate. They're all approximations of truth, and it correlates with DSA positivity. And in the no rejection biopsies, it also correlates with that. So below the threshold, the activity correlates so that this 4-part set of relationships exists below the threshold that we're calling positive and we're treating right now. This just shows you some of that data. This is the ABMR activity, and this is the cell-free DNA. And you can see there's a strong correlation in all the biopsies, and there's also a strong correlation in the no rejection biopsies. At any rate, we have to deal now with some new realities. But this brings me to where I'm most excited. I've been trying to find treatments for antibody-mediated rejection since I first started seeing it 40 years ago. And it's refractory to everything until felzartamab. and this is an anti-CD38 antibody. CD38 is expressed on many cell types, but it's expressed on NK cells and plasma cells. So we thought we would see a suppression of either or possibly both of these entities. So in the FELS study, what does a response to therapy look like? So this is the New England Journal paper that was published in May, and this is Kathy Meyer, who was the first author. There's a set of brilliant young European nephrology scientists who are going to really, I think, set the world on fire. And I'm privileged to be able to work with some of these people. So what Kathy's paper showed was that felzartamab treatment for 24 weeks suppressed microvascular inflammation histologically, MMDX ABMR activity, and plasma cell-free DNA, and it suppressed the CD16 bright NK cells. And there was a trend in this small study towards stabilization of GFR. There was minimal reduction in DSA. So it looks right now like the therapeutic effect is on the NK cells, not on the plasma cells. Now, by histology, activity recurred in some of the patients. But we looked molecularly, and this paper is in the final stages of review by one of the major journals. So we're looking at 3 biopsies each from 10 placebo patients and 10 FELS patients, the baseline biopsy, the end of therapy biopsy at 24 weeks, and the follow-up biopsy at 52 weeks. And we're doing sort of massive regression analysis across the whole genome-wide changes in these biopsies. So here's what we're seeing in the individual patients. And I guess one of the lessons here is we're approaching the patients as individuals now, and we're trying to avoid putting labels on them. We're looking at continuous activity in the individuals. Now, in the placebo patients, the ABMR activity some of the patients had one patient had almost no activity in spite of the fact that histology said they were active. And their cell-free DNA, their ABMR activity did not change through the study. In the FELS patients, it's dramatic. One patient had no activity and there was no effect of FELS because, again, this patient had histologic activity but no molecular activity. All the patients with molecular activity showed suppression of their activity, every one. All the patients with molecular activity showed relapse at the end of therapy by week 52. Except one, patient 4. And that one patient didn't get a rebound in his or her NK cells. So the patients are telling us something about how they're behaving and how they're mediating the disease. It looks like all these patients had a rebound in their NK cells and they all got relapse, and one patient did not get a rebound and that patient didn't relapse. Well, we're starting to see sort of universal trends in the data, not just the trends in some patients like we were seeing in histology. And the cell-free DNA showed the same things in the individuals, except cell-free DNA is a test that has some outliers in it. In this laboratory that did the cell-free DNA, you can get some rogue results. And except for these rogue results, I think that cell-free DNA is going to be how you're going to follow your patients on these anti-CD38 antibodies in the clinic. Now, what did this do to activity? The felzartamab patients, but not the placebo patients, didn't get any effect on activity. The felzartamab patients got suppression of the ABMR activity genes, the interferon gamma inducible and NK expressed genes, and they relapsed at week 52. And there was no net enduring effect of therapy. The ABMR activity genes didn't change. So they are stage genes, and we have changed the activity, but not the stage. Remember, this may have been operating for 8 or 9 years in these patients. So the ABMR activity genes are going to take a lot longer to resolve. So the immediate effect of treatment is suppression of ABMR activity, followed by a relapse in almost everybody and little durable effect. And there's really no change in the endothelial genes over this time frame. However, we looked at the injury genes. The black line is the slope of the injury genes between baseline and week 52 in the placebo patients. The red line is the slope in the felzartamab treated patients, and the black line is positive, injuries getting worse, but the red line is negative, injuries getting a little bit better. And when we looked, we think this may reflect some healing induced by this holiday period of suppression of ABMR activity. And when we looked between placebo and between baseline and week 52, the mathematics says that there are some genes which are better at week 52, and they turn out to be healthy kidney genes. And some genes are lower at week 52 as a result of felzartamab, and they turn out to be injury genes. So it looks as if what we're seeing, and this I think I'm quite excited about this, is it looks like a course of therapy can help some kidney genes that should be there get better and help some bad genes heal. At any rate, here's what we're seeing. What does successful treatment of ABMR look like? And we've been waiting for this for 40 years. It suppresses histologic microvascular inflammation, suppresses ABMR activity, and suppresses cell-free DNA. That's going to be extremely useful in the clinic. Effects on DSA remain to be determined. There's a trend towards stabilization of GFR, and MMDX is useful because it's superior to histology at measuring treatment effects, incomplete responses, and relapses. It separates ABMR activity from the endothelial changes, which I think is going to be very important going forward. And it reveals some slow improvement in the injury state in the biopsy. And in the long term, I think that it's possible that molecular endothelial genes and histologic and electron microscopic microcirculation changes will heal, but we have no way of guessing that for sure. We just have to find out from long-term therapy. So I think we're on the cusp of treating antibody-mediated rejection like we treat inflammatory bowel disease, ulcerative colitis, rheumatoid arthritis, and many other diseases. We treat continuously on the basis of the activity. We suppress the activity, and we hope to see long-term changes in outcome because of that. Anyway, that's what my take is on where we are. So this is a new era. We have new expensive treatments in the offing, and they work. Changing outcomes will require better laboratory support. And I would suggest we would like molecular biopsy assessment and cell-free DNA. Histology and DSA are valid. They're just not sufficient. And I think we need to start to think about managing the gradients of activity and not simply the dichotomous states. We're not on the verge of cure, but we're on the verge of much better management. Anyway, this is what we've covered. And I'd like to thank the organizers for this outstanding symposium and for the opportunity to be part of it. I wanted to be there, but unfortunately my wife sustained an injury and I've been doing nursing for the last 2 weeks. So I decided I'd better do this by Zoom. I'd like to also acknowledge the people who have supported this, Natera and One Lambda especially, and the brilliant people in the laboratory that make me look good. Thanks very much.